Good evening, everyone, and thank you for joining us. Welcome to tonight's clinical webcast. You have a text box on your GoToWebinar screen where you can enter your questions at any time, and we will discuss them at the end of tonight's webcast. Our moderator tonight is Dr. Morgenstern. He was the director of the recently released American Optometric Association evidence-based clinical report on myopia management. Thank you for joining us, Dr. Morgenstern.
Thanks for having me. So, first, I just wanted to, before I introduce our panelists tonight, I definitely wanted to thank OCULUS. OCULUS is sponsoring the discussion tonight. One of the things that I wanted to make everybody aware of is this device. It's called the Myopia Master. The Myopia Master is a device that it's a 3-in-1 and produces a lot of information for the user. It measures axial length, autorefraction, autokeratometry. It gives multiple axial length measurements. It really is something that is going to be really important to the clinician that is working with these patients. I know it comes with some great software internally, and there's also going to be some software that you can hook up with your mobile device to calculate and move the information forward. And for those of you who haven't used or worked with an Oculus device before, their portfolio is tremendous. They have great devices that measure not only axial length and autorefraction, but they have a device that I actually can't live without. I work and have worked in the refractive surgery world for years, which is called the Pentacam. It gives a measurement of the anterior and posterior surface of the cornea. And so we call it a corneal tomographer. They have lid assessment for meibomian gland dysfunction, visual field devices, and the whole library of devices associated with it. And with that, I'm going to turn off my screen and bring our panelists back up. You know, I've known these guys for quite some time. This is the second time around that this panelist is coming together. Dr. Cary Herzberg has been practicing orthokeratology and myopia management for over 35 years. He's lectured extensively on the topic and holds a patent on the first scleral orthokeratology design. He's lectured and written numerous articles covering the topics of specialty contact lenses, myopia control, and orthokeratology. Dr. Herzberg is a co-founder, president, board member, and fellow of the International Academy of Orthokeratology and Myopia Control, and the founder, former chairman of the board of the American Academy of Orthokeratology and Myopia Control, formerly the Orthokeratology Academy of America. He has visiting professor status at the Hai Hospital University in Shenyang, China. Dr. Langis Michaud graduated from the, Langis, I'm sorry, I know that you're dean of the school, but I'm going to pronounce it in English if that's okay. University of Montreal.
That's perfect.
Okay, great, because I don't want to slaughter your school's name. I'm sure you're very proud of it. Since 2001, he's working there as a full professor, and since 2020 as the dean of the School of Optometry. He's a diplomate of the American Academy of Optometry, fellow of the British Contact Lens Association, the Scleral Lens Education Society, and the European Academy of Optometry. Dr. Michaud has authored many articles in peer-reviewed journals about specialty contact lenses and myopia control, and has been invited to speak around the world on these topics. He's an editorial board member of the Journal of Contact Lens Research and Science. And finally, Professor Mark Bullimore. He is an internationally renowned scientist, speaker, and educator based in Boulder, Colorado. He's received his optometry degree and Ph.D. in vision science from Aston University in Birmingham, England. He spent most of his career at The Ohio State University and the University of California at Berkeley, and is now an adjunct professor at the University of Houston. His expertise in myopia, contact lenses, low vision, presbyopia, and refractive surgery means that he is a consultant for a number of ophthalmic, surgical, and pharmaceutical companies. This work has resulted in approval of, among others, Paragon CRT, Alcon's iLux, CooperVision's MiSight lens. All right, I am really looking forward to this discussion tonight. We really could not have put a better panel together. And I am going to start out with Dr. Michaud. Dr. Michaud, first question goes to you. Are you ready?
I'm more than ready, and welcome to everybody to this discussion.
Excellent, excellent. So we're talking about, OCULUS sponsored the event. We have the Myopia Master. We have, the Pentacam AXL that they have invented. Axial length is the topic, and I want to ask you the first question. Could you discuss the importance of having the ability to measure axial length as part of a myopia management specialty? How important is it to you, and how do you use it? Where is it in your information bucket that you have to put together on a patient?
In fact, the answer is very simple, and it will be kind of short. It's the metric to evaluate the evolution of a myopic eye. It's not the refraction. I compare it to my students as glaucoma. 30 years ago, we took intraocular pressure with the Goldman tonometer, and boom, we had the diagnosis of glaucoma, right? Over 28, it was, a glaucoma patient. Now, after that, it was, pachymetry came in. And then after that, the scan of the optic nerve, and then the visual field. And so you have plenty of elements to consider before, concluding that a patient is a glaucoma patient. Same thing for a myopic patient. The first thing first, obviously, refraction will tell you if the patient is myopic, but how this patient will evolve, the refraction will not tell you, because at a given point, and we don't have time to go in depth in that kind of discussion, but at a certain point, the metropization is broken, and the refraction and axial length is no longer matching. So axial length is the only way to evaluate if the kid is progressing, especially if you fitted the kid in orthokeratology. If you want to refract again that patient, you have to wash out the lens wear for at least a week or 2 weeks or 3 weeks or even a month going to baseline, and then you refract and you see if there is an evolution. It's not practical, not convenient for the patient. So axial length, despite the fact that cornea is slightly molded, will tell you if the kid evolved, and that's the only way, in fact, to evaluate if this kid is going in the right direction.
Awesome, great answer. Mark, I'm going to turn it over to you. Same topic, axial length. Would you agree or disagree with what Langis said? And if you can expand more on what role axial length plays in your world as it relates to myopia management.
Well, thanks, Andy, and it's great to be here. Langis, if that was a short answer, I'll look forward to the long answer. So I don't see patients. So I look at things from a consulting, an industry, a regulatory, and an advisory role. In clinical trials, axial length is the gold standard for evaluating the efficacy of therapies. And as long as you said, one of the reasons for that is some of our therapies either alter the cornea, or in the case of atropine, they have the potential to mess with the accommodative apparatus. So in clinical trials, it's the gold standard, and it's also more repeatable, and its axial length is very highly correlated with, vision loss later in refractive error. From a clinical point of view, as Langis said, if you're serious about myopia management, it's what you need to be monitoring, especially if you're looking at ortho-K. If you're just getting into the field, if you're looking at spectacles or soft contact lens myopia control, it will give you a more precise estimate of what's going on, but you can still tell how the kid is progressing by measuring refractive error. Of course, you'd like to do that cycloplegic, and you'd like to do it using an autorefractor, because although we don't like to admit it, the autorefractor is much better at monitoring progression than our retinoscopes. So if you're serious about this, or you're thinking about it, then you want to look at some stage in the future that you have this piece of equipment. But I would say don't let it stop you from getting started if you're not yet engaged in myopia management.
Great answer. Cary, I know what your answer is going to be. However, I'm going to pose the question a little bit differently to you, and that is, well, number one, would you agree that axial length is a gold standard here? And more importantly, could you, not more importantly, but just to take the topic a little bit differently, what happens if you're a practitioner that doesn't have the capacity or doesn't have something to measure axial length in the practice? Do you just not start? What do you do? Mark brought up that topic. And then I'll follow up with a couple of other questions for you.
Okay. Well, hi, Andy, and it's great to be here. And I, I love the beginning here, this question. But yes, I found as a process that axial length is indispensable as far as being able to monitor a patient's progress and knowing where you're starting, knowing if you have a patient that has a long eyeball or a short eyeball, basically is really important. And sometimes the refraction won't necessarily tell you that. And then of course progression is, it's fundamental for that. But to answer your question, we run into this all the time because we have doctors that want to do this, but can't make that investment first. So you can look at a cornea. I mean, if you I do mostly Chinese patients, so we see them early and often. And if you see a flat cornea right off the bat, and the patient's a relatively high, moderate to high myop, you better assume that you need to slow this down rapidly, because it's probably a long eyeball. So the steeper the cornea, you can rest a little bit easier, unless it's a really high, a much higher prescription.
Yeah. I'm going to follow up. One of the points that Mark brought up, I wanted to follow up with, and I'll toss this back over to Langis. Number one, how, as it relates to axial length, a lot of papers that I have read, and I know the back in 2016 when the FDA workshop met by me here in Maryland, they talked about contact versus non-contact axial length measurement. What's your opinion on that? And do you have a preference yourself on should you use a contact device or a non-contact device to measure the axial length of the eye?
The answer, again, will not be short, Mark. Sorry for that. So I prefer the optical devices, obviously, because the non-contact devices, because it's more precise, more repeatable, and you have a good matrix to compare from visit to visit. With the contact devices, I never know if I'm at the right place where I was 6 months ago. I don't know if I compress the cornea the same way. So there's a lot of bias from that measure that, can a little bit impact the result. But, these devices are cheaper, right? So I would prefer to have a non-perfect contact, biometer compared to no biometer at all in my practice, if I cannot afford the optical biometer. And when I'll be able to acquire the optical devices, then I'll move on the next on the new technology. And the rationale for that is that it will not only tell me a lot about the evolution of the kid, but it will drive from the start my strategy. Cary just mentioned it. If I have a kid of -3 with a very long eye, I will probably be more aggressive compared to the same kid -3 with a very short eye. So meaning that I will do ortho K plus, atropine plus, outdoor, and all other stuff we always mention to prevent myopia to progress. But we know that from 26 millimeter and over, the risk to develop visual impairment over the age of 65 is high. So I want to refrain everything and to keep the kid under the 26 millimeter value in order to be effective in my management. So it really not only measures the evolution, but it drives the way I will treat that patient. And any device that will provide me some information is helpful here.
Great. Mark, follow up to you. I know when we were writing our guideline for the AOA, for the Myopia Management Clinical Report, I must have cited you 5-6 times in that paper from the work that you did. 4, I'm sorry. There were more than 100 citations that we did drop some. So yeah, your work is imperative to the profession right now. So my question to you is, following up from that, do you have any research information on axial length of the eye? What do you consider a short eye for the new user? What do you consider a short eye? What do you consider a long eye? Where does the risk come in terms of axial length? Or is it individual to the patient? Or can you use this like a ruler and say, okay, a certain number and higher, I've got problems? Or is it individual to the certain patient that's coming into your clinic? What does the research say?
Well, I think we're in a period of transition where people have just found out about axial length and realized its importance, and we now have the tools to measure it, as people have said very repeatedly. At the moment, people, including Langis, is saying 26 millimeters is our sort of target to stay below. But of course, that's a nice line in the sand, much like emmetropia is a line in the sand, or 5 or 6 diopters is our criteria for high myopia. But we've got to remember that the data shows, the data show that for each additional millimeter, you're going to get an increased risk of maculopathy, an increased risk of glaucoma, you're going to get an increased risk of visual impairment. So it is a continuum, but 26 is a nice number to carry around. It's the number of letters in the alphabet, at least the most common alphabet. So thinking about that as what is normal and what's not. Now, the kids grow, and their axial length never increases as rapidly as when they first develop myopia. So it will sort of slow down in an exponential way. So it's important to predict for the future. The other problem with just using one number is males are different than females. Okay, so we should probably down the road have perhaps one number for women and one number for men, and maybe even for different races, or adjusted for refractive error or some other thing. Adjusted for height, okay? You know, if you're Alan Glazier size, you're probably going to have a shorter axial length than somebody who's the size of an NBA player, okay?
Absolutely. Gotcha.
So there's a bunch of things that we're still learning, but that'll do for now.
If I'm not mistaken, the research, Carla Zadnik had a paper looking at the emmetropization process of males versus females, and the numbers were a little bit different, if I remember correctly. I think she did it with, I forgot who she wrote that paper with, but I know she was first author on it. So completely agree with you 100%. Not that you need my validation, but you know, we're right on the same wavelength. You got it. Cary, slightly different question than axial length, but Mark brought up something that I do all the time, which is cycloplegic autorefraction. It's probably one of my favorite things to do for these patients because it gives me really good objective information. And so my question to you is, for the new user, is there a certain drop or drug that you're using for all of your cycloplegic refractions?
Oh, cyclopenolate is
the
go-to.
Okay.
Yeah, but we can use tropicamide too. I mean, I've done with tropicamide as well. I also do a dynamic retinoscopy on my young patients as well, and that seems to be correlate really well.
Gotcha. And how often are you doing a cycloplegic refraction on a myopia management patient? Is it an annual test that you're doing? Is it dependent on the situation?
No, as little as possible. I did the first visit, and after that, then I'm relying on axial length.
Okay.
As, you know.
Except if you see a big switch and the refraction or unexpected result or something that you can't explain logically, then you may go through that. But I totally agree, you know, cyclopenolate at the first visit, and if you need to get the second or the third or the fourth, you know, cycloplegic refraction, then go with tropicamide. It's more convenient, more practical, and it's as effective as cyclopenolate on a confirmed myope.
The other thing, just on the axial length issue, is that, you know, that's one of the nice things about the OCULUS Myopia Master and similar instruments. You don't need cycloplegia, so you can monitor a kid every 3, 6 months, 12 months, whatever, without having to cycloplege. Well, that's another important benefit of that technology. So to jump in, Andy, I won't do it again.
No. That's you know, I saw that you were thumbs upping the tropicamide before when Cary was talking about it. So I think, you know, for me, whatever the agent is, I typically use tropicamide 1%, but I do mark it in my chart. If I'm ever going to do a cycloplegic refraction and I want to check cycloplegic refraction to cycloplegic refraction, I'll make a note in my chart of what drug, obviously, and what concentration I used, just so I can have apples to apples instead of apples to oranges when I'm comparing.
If you're refracting a kid who's myopic, it doesn't matter which you use, and it doesn't matter in terms of the biometry, in terms of lens thickness and anything else you might want to measure. Obviously, with a strabismic or hyperopic kid, there are different considerations. But for myopic kids, tropicamide is just as good. That's what I would.
Got it. I'm going to switch up the order, so I give Cary the first crack at this question. So just for fun. And the question is this: how young do you start looking at your myopic patients for myopia management? So what is there something called too young to start myopia management for the new user, for the person who's starting myopia management in their clinic? What patients should be available to myopia management?
Strangely enough, Andy, it starts with the mother or your patient that's sitting in the chair, the adult, and her history or his history, and that's then going to dictate. I mean, you'd like to see that patient before school, certainly, but you know, if you have a patient who's giving you a myopia history and demonstrating what you don't want to avoid with the young patient, you want to see that patient as soon as possible. So you know, as soon as I can, basically, check the patient, even you know, a youngster under 1.
Got it. So have you started? What's the youngest patient you started myopia management on?
For Ortho K, 4.5, which is difficult for Ortho K, but atropine a little bit younger than that.
Gotcha. And could you talk to me about, since you're the Ortho K guy, talk to me about a 4.5, 5-year-old in Ortho K. How difficult is that, and what are the considerations that you have to kind of put into play?
Well, these are my kids, basically. I mean, I've adopted all of them. And your heart is in right there, you know, because you're doing something that technically there could be a problem. I mean, because wearing contact lenses is a risk factor. So, I mean, you're doing something you're going to be questioned on if something goes wrong. So it's, you know, you had to pretty good justification of why you would be doing it in the first place. After that, then you're going to do everything you can to make sure that patient is safe. And, you know, you covered all the bases with the solutions and care and everything else, and you're going to see the patient very often. And you're not going to sleep very much for a while. But
Gotcha.
it's been good.
Gotcha. Langis, follow up to that one on Ortho K and youngest patients.
Ortho K is not that difficult as long as you have good data to rely on. And the difficulty with very young patients is to acquire these, you know, valuable or reliable data, meaning that the corneal topography, corneal curvature, and eccentricity and all that stuff. So it's very difficult to acquire those data in a very, very young patient. But I agree that if you have to do it, you have to do it. To your previous question, I would define 3 different type of kids. And when I become concerned with myopia, in fact, I consider any kid myopic until proven otherwise, meaning that, you know, at the beginning, if he's not hyperopic enough, and we see that there are charts in the AOA guidelines, there are a very good table on that. You know, you can track by age what kind of level of hyperopia you can expect, and if you're lower than that, it's a potential myopic patient. If you track the axial length, then you know that in the year or 2 before myopia onset, you'll get a significant increase in the axial length before myopia onset. So you can reinforce a message on computer screen, reading, distance, lighting, outdoor exposure, all that stuff. Nutrition, even nutrition nowadays, we talk about that because we know that carbohydrates regimen will favor myopia at a given point. A French study on that. So this is the first kid that is not myopic, but, you know, potential to become myopic. The second one is the regular myopic patient, 6, 7, 8 years old now, minus half a diopter, minus 3/4 diopter, cycloplegic refraction, then regular myopia management will apply. And the third one is a tricky group of very young patients, very highly myopic patients, -7 at the age of 3, for example, or -10 at the age of 4, or even minus at the age of 2. So these are different kind of patients, because most of the time it will be related to neurological disorders or kind of syndromes, and they are not evolving that much, and not at a fast, they are not fast progressor, despite the fact that they're already -8. So the management is completely different, and habitually I refer these kids to the pediatric ophthalmologist to rule out any kind of neurological syndrome and to manage this condition if it applies. But, you know, it's a different approach. But Yeah,
Got it. Thanks. I'm gonna, we have a short amount of time. I'm gonna shift topics really quick. I want to turn this one over to Mark. I want to talk about the anti-muscarinics, if that's okay, for a second. And could you tell us from a research perspective, what have we learned about atropine in the last 12 to 18 months? Can you talk about what the research tells us about rebound effects? This is a completely separate avenue than orthokeratology. Professor, take it away.
So in terms of higher concentrations of atropine, 1% and 0.5%, they're still the most effective therapies that we have based on the evidence-based literature. Of course, they carry with it a heavy burden of psychoplegia and mydriasis, so that's not something you want to inflict on every patient. But there are places around the world and people who practice in the US where, as a routine, they will put an early onset myope, say 6 years of age with a sharp trajectory, they'll put them on 0.5% atropine. Now, at the other end of the spectrum, we're learning a lot more about low concentrations, specifically 0.01%. And a lot of people grabbed a hold of that because of some preliminary, I'll call it preliminary data out of Singapore in the ATOM studies. What we've learned in the last 12 to 18 months as a result of multiple randomized clinical trials published in really top-rate peer-reviewed journals is that 0.01% is not as effective as perhaps we first thought. It's only slowing myopia by about a quarter diopter in the first year and axial elongation by less than 0.1 millimeters. We can do better than that, either with a higher concentration of atropine or with other approaches. So what I tell people with atropine is be the doctor, okay? Don't just reach for a drop in a prescription pad and forget about it. If you were managing a glaucoma patient, like Langis' analogy earlier, you check the pressure to see whether you'd met your target. So you want to see with low concentration atropine, are you given the maximum dose without disrupting the kid's lifestyle in terms of photophobia or loss of near work? So I encourage people to perhaps play around, start on one eye, see what sort of response you get in terms of loss of accommodation, and then make an informed decision, discuss it with the parent, what you're doing. So that's kind of, it's like the atropine story is evolving, I would say, faster than anything else. If you ask practitioners who are doing myopia control, particularly ophthalmology, they're still reaching for the 0.01%. But we've learned in the last 12 to 18 months that other concentrations should be our first frontline treatment.
Gotcha. And in terms of, I've had new practitioners come up to me in conferences and ask me about atropine. How do I use it? When do I use it? What strength do I use it? And then the big question I get is there such thing as a rebound? Is a rebound a real thing? Does it exist? Does it not exist? Or maybe I over-prescribed and the patient has an accommodative issue afterwards? What is the literature telling us about rebound?
We have very little data. Most of the data we have on rebound comes from the ATOM studies in Singapore. And basically the higher concentration, the higher the concentration, the greater the rebound. So just taking 1%, okay? The control eyes in that study progressed by about a diopter and a quarter over 2 years. The treated eyes progressed by a quarter. So there was a slowing of a diopter. But then there was, after they withdrew the treatment, there was a tremendous acceleration in the treated eyes. They progressed in that sort of washout year almost as much as the control eyes progressed in the previous 2 years. The evidence that we do have suggests that there's not much of a rebound when you're down below 0.1%, okay? But the data are very thin. Now, my colleague Mel Brennan says with any therapy for myopia, you should assume some rebound. Ironically, they didn't find any in one of their J&J contact lens studies, and the evidence for rebound in ortho-K is pretty thin. We'll see some additional data on MySight. Remember, the MySight kids have now been in the study for 6 years, and they were then washed out, if you like, for a year. And Paul Chamberlain's going to be presenting those data at the Academy meeting in early November. So that's going to be fascinating to see what happens there, because it's a very well characterized cohort. Now, of course, the average age of those kids now is 16. And we know on average, myopia is probably pretty stable by that age, okay, on average. So we have to take that even with a grain of salt. But I wouldn't worry about rebound and worry about that in your choice of therapies. Do what's right for the kid. And we don't have any data on tapering, okay? It's just seat of the pants stuff. But if you are treating a kid with a higher concentration, I would say above 0.1, you've got to think about at some stage tapering. But we have very limited data.
Got it. And Cary, I'll follow up with atropine to you. And I want to know, how do you, well, number one, do you use combination therapy in any kids, atropine and a contact lens? And how do you do it? And how do you know when to, where do you draw that line in the sand that says, I've got to commit to using a second treatment now? What puts you over that line in the sand?
It's the axial length. I mean, if you see the big changes in axial length that are happening, then you're going to add the atropine. And 0.05% is the one we've gone to now with the LAMP study. We began with 0.025, but now it's a 0.05, and it's very effective. You could see the numbers tapering down on follow-up visits. So it's and of course the thing is that how long is the eyeball to begin with? I've got an Asian practice, so we talked earlier about different guidelines for different groups, ethnically speaking, and these are the most at-risk patients, I think, in the world right now, the Asian population, and so they can do very quickly, even at into teenagers, they still change. So you want to stay on top of all of that. So axial length is indispensable.
Totally understood. Completely agree. I live in Washington, D.C. We have a very ethnically diverse population here. I actually have quite a few kids, and I don't know if you know the answer to this, but because your population is primarily Asian and myopic, we have some kids that are coming in now that have one parent that's Asian, one parent that's Caucasian, or any other ethnic diversity, but one parent being Asian. Is the risk factor still there with one Asian parent as there is with two, or do we not know yet?
For my limited observations, it is, because they pick the myopia. I mean, I talked to them too about, this should be fairer than this. You tried, 50%, but it doesn't work that way. I don't believe. They're predominantly myopic, and the dad will bring them in sometimes. The dad's the Asian, or the mom will, or perhaps Caucasian, or other. And then you just know, you're looking at that eyeball, and they might not even look Asian, but that, looking at the axial lengths of that and the age group. So they're just longer. They're just longer than anyone else. Longer eyeballs.
What's your do you have a go-to first line therapy for most of your patients? I know Ortho-K is your passion, but does that make it the first line therapy for most of your patients? And if so, why? And if not, why?
Okay, well, it is because of its lifestyle. I mean, you get these little guys and gals in there, and they're athletes too, and they're very active, and they want to be doing more. It's tough to, and I understand that my process began before we had a multifocal soft contact lens like my site and Natural View to use, and I use those as well. But my preference is the freedom of lifestyle, and I think that's the most awesome gift I give to my patients. We're hearing all the time, like, this is a game changer for them. It's made all the difference in their lives, and they don't even remember what it was like to wear contact lenses or glasses during the day. Sometimes their parents want to take them out of it later on, when they're more grown, and it's a shock, because this is what it's like. I want to go back to Ortho-K again. I don't want to wear anything during the day. It's freedom. Like LASIK. It's really very similar. It's a marvelous, amazing thing.
I think one of the coolest parts about our profession, and look, at the end of the day, we're all optics nerds, but we all kind of thrive on the same stuff. And that patient coming back after LASIK that comes into your office and gives you a hug because they can see 20/20, spectacle free for the first time. The orthokeratology patient that can see spectacle free for the first time, and the look on their face. Or, you know, Langis, I know you've experienced this because you work with some really challenging corneas in your clinic. You know, that keratoconic patient that puts a scleral lens on for the first time and can finally see distortion free for the first time in a while. You know, that's amazing stuff. On the topic of keratoconus, Langis, I just want to ask you, you know, for me, I've had 3 patients in my career that have been referred into me from people that are doing orthokeratology, that their best vision that they can get out of these kids was like 20/25. Never can get a sharp 20/20. And it turned out that these 3 kids that were referring to me, we pulled them out of their contact lenses, like you said before, for quite some time, let the cornea relax a little bit. And we found that they were actually keratoconic patients instead of myopia management patients. Could you talk to me about your, I know you work with these heavy duty corneas sometimes, your screening process, your intake process on a new myopia management patient? What tests are you going through? What are you doing to make sure that they're the right candidate for myopia management?
In fact, any kid that is myopic and is evolving is a perfect candidate for myopia management. And there's no single magic bullet for everyone, meaning that we have a lot of tools available in our hands, and we can, you know, apply these tools depending on the condition of the kid. So customization is a key word here. So, but as for the screening, obviously, you know, we talked about cycloplegic refraction, but my first step is to check for binocular vision. Binocular vision has an importance in myopia, and certainly the lag of accommodation, for example, is not a risk factor for progression, but it's a risk factor for myopia onset. So you have to treat everything that is possible to treat with vision therapy before, you know, implanting myopic surgery. I strongly believe that. If you have a lack of accommodation, for example, and you are using MiSight or a soft multifocal contact lens, part of the add power may be used to fix binocular vision issue instead of controlling myopia, and then you have, you know, a less favorable outcome. So you have to address binocular vision first and foremost, and to treat everything that you can. The second thing is to look at the eye and to get reliable data, as I mentioned. And part of it is to get a very good topography or tomography, and it's even better with, you know, both surface of the cornea. You know, we see kids at 7, 8, 9 years old, and sometimes we know that keratoconus will develop at, you know, 15, 16, something sooner, something later than that. But you see on the posterior face of the cornea and surface of the cornea that something is going wrong already, even if the anterior surface is perfect. So in those kids, or if I get irregular cornea in the front surface, I refrain myself to go to orthokeratology, and Cary can comment on that. But, you know, for me, because I have other tools available, I don't want to have this lens to be the trigger for keratoconus at a given point. There's no study on that, right? There's no, you know, long-term longitudinal with different cohort proving that keratoconus can be triggered by ortho-K. But if you have an irregular cornea, I would prefer to go with soft multifocal lenses and or combined therapy with atropine and soft contact lenses and or anti-myopia glasses. It's not available in the United States, but we have very good anti-myopia glasses from Hoya or from Essilor or from, you know, other manufacturers around the world. So that's another piece of a tool that we have to play with, and certainly, so topography, ocular health, do your slit lamp, your retinoscopy, your good old retinoscopy. If you don't have a good reflex, and it's not a scissor reflex, but it's not a very good reflex you're used to, then it's becoming suspicious, and then you may prefer to have you know, soft lenses instead of ortho-K. My clinical experience is if you are not able to customize your design in ortho-K lenses, as Cary and myself are doing, if you use just regular ortho-K lenses, it may be more difficult to achieve very good results with low myopic patients, lower than -2, from 0 to -2. Studies prove that you don't have enough plus and spherical aberration entering in the system, and we know that there's a dose response. Blink study proved that. So you have to generate a lot of plus, even for these young low myopic kids, and you have to customize your ortho-K fit. But with regular ortho-K lenses, it may not work as you expect. So soft lenses may be better. The pupil size is very, very important. So if you have a very small pupil size, 4.5 millimeter or less, then ortho-K maybe not, the perfect scenario for that kid. And then combined therapy can help you, because the dilation of the pupil with atropine will help you to reach a more favorable outcome with ortho-K. So you have to play with those tools, and there's no, again, single magic bullet. You have to do your management one kid at a time, customize every approach for every kid you have.
I couldn't agree with you more. Yeah, Cary, go. I was just going to say, remember that we have to wear a tool belt, and that we have a lot of tools in the tool belt when we walk into that exam room.
Isn't that amazing? Because that's really the guts of a specialty care, and that's why I enjoy this so much, because it's not just cookie cutter.
Right.
It really takes involvement. I mean, you're there. I just enjoyed that, what you just, Langis' explanation. That was beautiful. It's awesome.
Yeah, Langis, I mean, completely agree. You hit on something that you have up north that we don't necessarily have as much access to. I'm going to turn it over to Mark for a second to talk to us about when will the U.S. patients have access to the spectacle technologies that Langis was referring to, the stuff from Essilor, Hoya, Cyclass, all that kind of stuff that he was mentioning. Could you give us some information on that?
It's going to be a while, because all optical devices in the US are regulated by the FDA to a greater or lesser extent. And whereas if you want to introduce a single vision spectacle lens and sell that in the US, that's no big deal. But if you want to make claims about a therapeutic benefit and slowing myopia progression, well, the FDA is going to need evidence to support that claim, and they're going to need it on preferably a US population, or at least one that looks like a US population. So my site, CubaVision, they didn't have any US patients, but they had Canadians, United Kingdom, Portuguese, Singapore. So as a cross section, it was a fairly US looking population. So where are we along this journey? As far as I know, Essilor and Hoya have not started any clinical trials in North America, and the only published data on their lenses are in Chinese or Hong Kong patients. So they're going to need to produce something, probably at least 2 years of data, before the FDA will allow them to market those lenses in the US. Now, Sightglass, who now have a relationship with CubaVision, they're a little bit ahead of the curve, in so much that they're probably in the third year of a 3-year clinical trial. So they'll probably be closing their clinical trial or finishing their 3-year examinations sometime early next year. So that'll be the one to watch in terms of new spectacle technology. PALs, I really think you're wasting your patients' time and money. But if that's all you got and that's all you can use, that's fine. Executive bifocals may work a little bit better, based on the evidence from a study in Canada, they do. But again, they're butt ugly. Okay, not every kid wants to wear an executive bifocal. So unfortunately, we're going to have to wait and learn from Langis' experience and let him talk about his patients before people in the US actually get their hands on DIMS and Stellust, which are the Hoya and Essilor products.
Gotcha. And, obviously, like you were saying, the Bullimore prophecy of whatever you got, do something. Don't let these kids kind of fall through the cracks.
You got other tools, and there's a lot you can do. And we talked a little bit earlier about premyopia. We know in a young child, if at the age of 6, if they have less than or three-quarters of a diopter of hyperopia or less, they're at high risk of becoming myopic. Doesn't matter about their parents. If they've got a little hyperopic buffer, they're at risk. So you can start the conversation then, and you can also do some good by encouraging them to spend more time outdoors, because we know in terms of myopia onset, that will make a difference.
Yeah, and I was just going to get to that and go back to Cary with this point over. No, that was a great transition. Thank you very much. And that is, your in your clinical world, in your practice, You talked before about the genetic component, the strong genetic component of all of your patients. But as we all know, there is a strong environmental component to myopia as well. And, you know, this is the first time in the history of man where we've taken infants and, you know, toddlers and stuck a digital device in front of their face for hours on hours.
Yep.
Could you talk to us about digital device use? Is it not bad? Is it worse than we think it is? Is it what some people say, the new smoking of our generation, I guess?
It's an old term that's come back to roost, the computer vision syndrome, which is, you know, more than 2 hours in front of a screen a day, no matter what you're doing with it. It's an incredible thing to experience this with the kids, especially because they really have like attributes of a pre-presbyopia at that point. I mean, youngsters that are, you know, have text, their accommodative reserve to the limit. It's amazing. I mean, the parents are unable to deal with this at all. I mean, they've kind of given up. I think society's kind of walked away from the whole thing too. So here we are as eye doctors, right? That we're the last line. You know, who's going to stand in here and say this is wrong? Right. So there's no question that this, if you can't prove at least myopia progression, you're proving eye abuse. I mean, you know, this is just long-term abuse of the visual system. It's repetitive stress injury. You can imagine what that's doing to all the rest of the parts of the body, but the eyes as well. And these are kids that when they get to middle age, you know, what's the guess here and what their body's going to be like and their eyes and vision are going to be like. So I think you have to really step in here and do something. We are actively working with, you know, what we call visual hygiene, with teaching harm and distance, teaching working distance, demanding that these kids get away from these screens and do something else for a while. You know, taking the 20-20-20 rule if we can, whatever we, you know, it's not uncommon just to stick that your knuckles up there and elbow and show the child just exactly where they need to put that, you know, whatever they're trying to deal with. And the other thing is that you want to get them away from the smartphone if you can, and get them into, if they're going to have to do this, do it on a desktop that's 2 feet away. I mean, a really nice monitor, and then the ergonomic situation below eye level. You know, you can't look at a screen straight on. These big screens, it's more difficult. The eyes don't converge very well. You got to look down at a screen. So, yeah, it's yes.
I was going to say, could you talk to me about, you know, the other thing is, you know, I didn't even put 2 and 2 together for quite some time, but think about how, if, you know, I walked around malls around here. I'm sure you guys, well, pre-COVID, I guess, I was walking around the mall where parents would, you know, use the digital device as a pacifier for the kid in the stroller. And so the kid is holding it. But you got to remember, their arms could be 9 inches long, you know, as compared to adult arm length. And so they're holding those devices incredibly close to their face, and to me, that's, you know, that poison pill is a lot stronger.
It's child abuse. Is what it is. It's child abuse. I mean,
and,
you know,
go on with that, and please talk to me about like pre-COVID versus post-COVID. Has it gotten worse because of us, you know, keeping these kids inside for so long?
I think it's become justified because of the activities that the kids are doing now with the computer use in school, you know, doing virtual online. I think it justifies everything else, and it really doesn't. I mean, to the parent, though, it's like, you know, that was the final straw. They come to me and their arms are raised. What can I do about this? So, you know, it's all in there. I mean, and you know, we look at generations to come. I mean, you know, if we don't do something, if we don't stand up and do something for this, I mean, who else will do this? So it isn't happening.
If you look at a study made in China, obviously it's in Asia, but they look at the cohort of a lot of patients, obviously, you know, thousands and thousands of patients, and they identified that between the age of 6 and 8, they compare the average myopia level as of prevalence and the intensity of that myopia for the last 5 years. Let's say that they took, you know, the highest numbers and the highest myopia level in the last 5 years, and they compared to last year after 1 year at home doing, you know, schoolwork online and remotely, and they found that every group of age between 0 and 18 years old had a higher prevalence of myopia, but the worst was between 6 and 9 years old. So the younger were more affected than the older one. They double, triple, and even multiply by five times the prevalence of myopia in those younger groups. after 1 year of COVID. It's not only the distance is very important, lighting also, but the Generation R study made in the Netherlands in older patients, young adults, proved that 15 minutes of smartphone before bedtime delay the sleeping habits. And we know that especially in kids, if you don't get enough sleep, it's a factor for increased myopia as well. So it's not only the device itself, but its impact on all the behavior of the kid that is really triggering myopia.
Amen to that. I mean, what is it about? They don't sleep. I mean, and they go to bed like 4 or 5 o'clock in the morning. You know, you get them back in here. When did you take your lenses out? Well, 11 o'clock, 12 o'clock.
And the other population that we forget is this population of young adults. I see these kids, these young adults coming at university, you know, first year, -3 in average, -4, -5, you know, it's increasing every year. But after 5 years, they are, you know, 2 diopters more myopic because they are spending a lot of time on computer. And we are correct, they are optometry students, and what we are fitting on them, regular single vision lenses. That's not making sense. That's not making sense. We have to control those young adults as we control the kids. And for me now, I don't consider myopia stable until the age of 25.
Mm-hmm.
You know, and that's my goal. You know, I'll drive you to 25, and then you'll get LASIK surgery. But I'll do whatever I can. Obviously, ortho-K at the beginning, when they become to drive and more active evening time, ortho-K is maybe less convenient because of the design of the lens we put there. It's not myopia correction, it's myopia control. So the treatment zone is smaller, the plus is more in the pupil, so more halos, more glare, more anything. So we have to switch over soft lenses or something like that later on at 18, 19, 20 years old. But still, we have, you know, myopia control to sustain at those ages.
Yeah, you know, one of the things, and I'm going to go to the lightning round because we're running out of time right now in a second. But one of the things I always remind my parents is that, you know, these kids that are coming in, like you said, Langis, they may or may not, but they may want to have refractive surgery when they get older. To a refractive surgeon, not the myopia management doc, but the refractive surgeon, there's a big difference between a -8 and a -5, you know, in terms of the rate of enhancements of multiple surgeries, the rates of 20/20, the amount of ablation depth that goes on, how much corneal tissue has to be removed. So that, to me, I have that conversation with the parents that, you know, by doing myopia management, you know, are you going to get your kid to 20/20 uncorrected with nothing? Of course not. You know, some things, are you going to still be myopic when we're done? Just less myopic? Yes, but that's going to play out not in just in the disease risk population later in life, but also in the candidacy for refractive surgery population. And I think that's a very important idea to bring, because refractive surgery is only going to get better with time. And many of these folks will want to have it. And so I think it's an important discussion to have with the parents as well, to say, hey, you know, you're increasing your odds of candidacy for refractive surgery if you keep your kid at a lower amount of myopia starting now. And so just something to think about. All right, everybody gets a minute because we're real tight on time. I'm going to start with Mark. Here's the question. In your opinion, what is the single most important pearl, clinical pearl, research pearl, whatever you want, that you can provide for a doctor considering starting a myopia management specialty?
Well, first thing I'd say, and with due respect, is unlike a lot of the last 5 minutes of conversation about electronic devices, we need to be evidence-based. And when it comes to time outdoors, the evidence is strong in terms of slowing or delaying the onset of myopia. In terms of its effect on progression, the evidence is thin. The association with smartphones and myopia is also very thin, okay? But obviously there are broader public health issues that were touched upon. So use the data from the literature, learn about what you can expect from your various therapies, and apply that in your practice. Do not overpromise. Okay, some of the calculators out there are fantasy in terms of the amount of slowing of myopia progression that you can achieve. You want to slow things by a diopter. You want to slow things compared to the previous year. Those are reasonable goals. And use the tools available. And find a mentor, find a peer group that you can work with. Lots of people online talking about these things, but do it, because it's the biggest public health threat to the eyes of this century.
And finding a mentor in a group, I'm going to push it over to a guy that maybe has attended a conference or two on orthokeratology, who has some great mentors under his belt. Cary, what do you think is your clinical pearl that you'd want to share with any docs considering a myopia management specialty?
You've got to separate. It's specialty care, no matter what you're going to call it. If you're going to do myopia management, right? And you have to separate them from vision care plans. Basically, they don't work together. And you can certainly use the vision care plan to recruit patients, but you must separate them after that, because the care that you're providing is much bigger than a vision care plan would ever. When I used to take these plans, the patients used to say, well, I'm not eligible for a refraction for an exam because it's not, my vision care plan won't pay for it. Well, that's not when you're eligible for an exam. It is when you need to do it, when it should be done. So that definition will help you anyway as a young practitioner, as growing a practice, because it's going to start defining you from the herd, basically, and making you as Newton used to say, Newton Wesley, make you a legend. So
great, thank you very much. And and I just got to thank you for all the putting the orthokeratology conferences together over the years have been amazing. I mean, really amazing. I've learned a ton myself. I know thousands and thousands have as well. And great job. You've really done a lot for the profession.
Seeing the community grow with this myopia thing now, I mean, we saw that years ago this was going to happen, but it took forever, right? But now we're here, and the momentum that's building is just amazing. I mean, I'm glad to be here to be enjoying this. This is just what we thought maybe would happen.
You've logged quite a few miles on airlines, all three of you guys.
God.
Langis, you're up next.
Yes. First thing first, educate yourself, and that's starting with this webinar and other conferences and all that stuff. Be comfortable with your knowledge about that. Start one kid at a time. The easiest way to do it is -1 patient. Put a soft multifocal lens because you're used to fit soft lenses. If you're not comfortable with orthokeratology, you will learn. But start with the next kid. The worst thing you can do is still to provide single vision glasses to an evolving kid. It's not standard of care anymore. And include your staff. Include your staff, because they will talk to parents, they will educate parents, they will train the kids, they will answer the phone, they will answer questions, and they will manage your agenda, because your agenda will no longer be what you are used to if you are doing myopia management, because it takes time. You have to be open for emergencies, you have to answer questions, but it's really rewardable and charge for what you're doing, and then you'll be able to pay for the equipment we mentioned tonight, and you'll be more performant in the field. So, but include your staff. That's very important. That would be my pearl.
That's great. And guys, at the end of the day, we're helping kids, and that's really the most important thing. And you do the right thing. You always do the right thing, and I think it's really important. I got to tell the three of you guys, I have learned tons from all three of you over the years, and still going to learn from all three of you guys. Hopefully we can start seeing each other at more conferences in the near future. I know I'll be at the Academy the first week of November. I think Mark was talking about that up in my college alma mater in Boston, so I'm very excited to get back there. I do want to add, and this is a little bit of a self-promotion, but I think it's really important. The American Optometric Association, we put together, we got a group of folks together, and we developed a clinical report on myopia management. Like Mark was saying, an evidence-based, purely evidence-based clinical report. I used information from all three of these guys that are on the screen over here to put into that guideline with our team. It was a real big team effort. It's available for free for everybody. If you go to the American Optometric Association homepage and look for the evidence-based clinical reports, It's listed on there, and you can open it and download it. And I think, you know, all myopia management, especially right now, is a work in progress. It's evolutionary. I think things are going to change as we learn more and as more and more devices come out and get better and better. All that information is going to change. But like Cary was saying and Langis was saying, reach out, and Mark was saying, reach out to other folks out there. Optometrists and people that work in our profession are great people. Everybody wants to help each other out. At the end of the day, it's all about these kids, and everybody should want to do right by them. So with that, guys, I can't thank you enough for spending an hour of your evening with us. For those of you on the line, thank you very much for taking time out of your night. If you're on the left coast, it's not so night out there, I guess, but we really appreciate it. And I just want to say thank you again to OCULUS for sponsoring this event. And I'm sure we're all available. If everybody has any questions, I'm sure you can reach out to any one of the four of us, and I'm sure we'll all help you as best we can. And with that, I'm going to turn it back over to our organizer, Michelle from OCULUS. Thank you very much, and have a great evening.
Thank you, Dr. Morgenstern, Dr. Michaud, and Dr. Herzberg, and Professor Bullimore for the great discussion tonight. And this concludes the presentation on behalf of OCULUS. Good night, everyone.
Thanks. Take care.
Thanks.
Thanks.
Good night.